Inspiring Uganda.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.
Thank you so much for keeping it with us here on UBC TV. I'm Robert Chirabo Nyonyitono, in case you've just joined, and welcome to this edition on International AIDS Day or World AIDS Day celebrations that occur every 1st of December. Now here we look at how far we've come in the fight against HIV/AIDS, what needs to be done, how do we move forward. But this time we also have special emphasis on ending, that is stigma and discrimination among people living with HIV/AIDS. And to discuss this and more, I am honored to have two guests that I believe we shall have a very fruitful deliberation as we handle issues in the fight against HIV/AIDS, where one of them has been stigma and of course discrimination, where there is always these problems, even when these people we all know are just like us. With HIV/AIDS, as long as you're on treatment, there is no difference with anybody else, because at one time you suppress the infection, and when it's been suppressed, if you are to look at the 95, 95, 95, that is the global target to end HIV/AIDS by 20, 30 few years from now. As long as we stick to that, then we shall have no HIV infections. Those are who will be sick, will be on treatment, they won't be able to pass on because the viral will have been suppressed, and then we shall get to that dream. So with me is Dr. Daniel Byamukama, who aids HIV prevention at the Uganda AIDS Commission. You're most welcome, Doctor.
Thank you.
And just next to me is a very beautiful young lady, and that is Ruth Akul, who happens to be a member of the National Adolescents and Young People that look at prevention of HIV/AIDS, and she is a committee member. You're most welcome.
Thank you so much.
I'm delighted to have you this morning on this show. Now, just to give shape to the discussion, I'll begin with you, Dr. Daniel. When we talk about Uganda AIDS Commission, what is Uganda AIDS Commission? What do you do? For a long time, people have heard of you, I may know, but our viewers need to know who we are with. Where do they get the authenticity and authority to speak about this on this occasions and special day?
Thank you. Thank you. That's an important question, because as you rightly say, many people misunderstand what the Uganda AIDS Commission is about. So the Uganda AIDS Commission is a government agency under the office of the President. It was formed in 1992 after the President discovered that the response to HIV is not a health response. It's not only doctors who will participate in the fight against HIV. It's not the Ministry of Health only that will participate in the fight against HIV, but all other sectors and institutions, including religious institutions, including cultural leaders, including education sector, including gender sector. So they formed, the parliament constituted the Uganda AIDS Commission to be the overall coordinating agency for all sectors, including the health sector, the education sector, the religious leaders, the cultural leaders, so that all of them are implementing one plan. Everybody's effort is aligned to each other's effort, and we give guidance, the overall guidance and direction and leadership to the national HIV response, and we report. So we generate a national report, we report at the global level and the national level by getting our reports from the various sectors and players. So we are the overall coordinating agency, the overall leaders of the national HIV response in this country.
Okay, now having told us how you're the overall, so briefly give us an overall picture of how we are standing as a country when it comes to HIV/AIDS.
Thank you. I think where we are standing now, in terms of numbers, we estimate we are about slightly 1.4 million people living with HIV in this country. And a significant number of those, like 1.2 million, slightly more than 1.2 million, are already on treatment.
That is good.
That is good. But we have a challenge. As I talk about that, as we estimate, we would expect around 20% of the 1.4 million I've talked about. We have not yet identified them. So there's a challenge with HIV testing. So the 1.4 million, we arrive at that 1.4 million through a scientific methodology. Using science and mathematics, we compute if these are the people we see among pregnant women, how many could there be? So we have a methodology of reaching at the 1.4 plus people living with HIV. But in all honesty, we estimate that 20% of those, we have not yet reached them, identified them. So we have 20% of those, they are down there in the communities, they don't know they have HIV, and that means they continue to transmit HIV unknowingly. So I want to take this opportunity to call upon all our people. As you rightly said in your introduction, if you identified that you have HIV, you start treatment on time, you live a normal, vibrant life. My sister seated next to me is about to make a disclosure, how she lives. So you live a normal, vibrant life. So we would want to encourage everybody, including the young people, to come out and test. Last year, we lost 17,000 people due to AIDS-related illness. That is a big challenge. According to the Presidential Fast Track Initiative, we shouldn't be seeing anybody dying of AIDS-related illness because we have treatment, very good treatment. So that's a challenge. And we see that a significant number of people who are dying, most of them had never tested. I call upon people to test. The second group that is dying from AIDS-related illness are those who start treatment, but because of some conviction or some issue, maybe a religious leader has promised them a miracle, they abandon treatment. So we're calling on our people who are on treatment, adhere to treatment. I think the third indicator I wanted to highlight in terms of the picture is the number of people contracting HIV. Before we went into the COVID lockdown, we had estimated that 38,000 people were contracting HIV per year. When we went into the lockdown, we went into a slight reversal. Last year, we registered 54,000 new HIV infections. 54,000 new HIV infections, that's a very big number. Still very high, and a significant number of those are children. Children born to mothers living with HIV, who were 6,000. According to the Presidential Fast Track Initiative, there is no child who should still be born with HIV in Uganda, and I hope as we go along, we shall discuss what are the challenges, what do we ask the individuals down there in the communities to do. And another significant number were young people. Young people between the age of 15 and 24, they were 20,000. But out of the 20,000, young girls contributed a significant proportion, 3/4. So 15,000 out of the 30,000 of new HIV infections among young people were among young women. As we go around, I hope we shall have time to discuss what do we need to do for our young women to minimize their risk of acquiring HIV. Of course, the others were adults, and in general, most of the new HIV infections were among women compared to men. So even when we talk about the total number of people living with HIV in the country, we see that there is a gendered pattern. There are more women than men. Around 830,000 are women, and around 500,000 are men. So you can see the women are much more, though in the general population we are almost 50-50. So that is the current picture. On treatment, we are doing well. You talked about the 95, 95, 95. So the 95, 95, 95 refers to the target to have identified 95 people living with HIV, to have tested them and told them, look here, you have HIV. 95%. I told you we are just at 80% or around 81%. So there is a big work to do. But for the second 90, would want to say that all the people who have been identified to be living with HIV are linked to the treatment, the good treatment we have. We are doing very well there. 96% of all our people who have already identified are already on treatment. So you can see we're already beating the 95%.
Already on treatment, but then
on treatment, we're already beating the 95.
Around the 95,
Yeah.
I'm more excited with the last 95.
Perfect.
Which is have been able to suppress.
And you're so spot on, because the whole objective of putting our people on treatment is to help them attain virus suppression. When they attain virus suppression, it means they will live a normal, healthy, vibrant life. It means they will not transmit HIV to their loved ones. So that is key. There, we stand at 92%. 92, you can see we are not far from the 95. And we believe if we work hard, as we shall be requesting you today, the listeners, we believe by 2025, even that 95, we shall have achieved. So the main challenge is on the first 90. Testing all our brothers and sisters who are actually living with HIV and they don't know. We shall discuss the measures we have put in place to make sure we reach everybody and nobody gets left behind.
Well, I earlier told you on this day where the world celebrates or commemorates a World AIDS Day, please, I call upon every Ugandan, everybody watching this show, the best gift you can give yourself today is going for an HIV test and know your status. It will have no meaning for you to be among people on planet Earth on this day when you do not know your status. Please, please go and get to know your status. If it is found out that you're positive, get on treatment. Treatment is available. Start on treatment. And when you start on treatment, please adhere, take that treatment religiously. Then what will happen? You suppress the virus. You live a normal life, but also you help us not to have new infections because it will almost be undetected. And once it's undetected, you can't transmit. However, even when you find out that now you can't transmit, please stay on your treatment. Many of you there say, I had a miracle, katonda yamponyeza, and all that. Then you quit treatment and you relapse. Together, we can have a free HIV/AIDS Uganda. Now, this brings me to my little sister here. When you talk about the problem of stigma and discrimination among persons living with HIV/AIDS in our country today, one would say maybe since the 80s, when we first registered our first case, that's at Kasenselo landing site in Chotera district. Years have passed. We wouldn't still be seeing discrimination when I'm moving in communities here. People will tell you, Sirimu katiguafu kamusuja. You know, HIV is just like a fever. You know, would we still expect discrimination? Is it still there? Please.
Okay, thank you so much. So, yeah, it's easy to say that HIV is a fever. It's now like a fever. But
young girl will tell you, I'd rather becoming pregnant, I'd rather get HIV.
It's because they don't know the reality of living with HIV. So with that, living with HIV, there are always other challenges that come with it that very many young women don't know. For example, the self-stigma that you go through. So even just besides the social stigma that you receive, but there is also that self-imposed stigma that you have to first deal with. And that is what very many young women, especially those who say that I would rather get pregnant than getting HIV, but sorry, I would rather get HIV than getting pregnant, because they feel that with HIV, it's not, you know, seen. You cannot test with your eyes and know that someone is living with HIV. But with HIV, yes, people don't know, but you are the one who knows what actually you're going to go through living with the virus. There is always pill burden, and we are praying very hard that we have the injectable at anytime soon. So there's also even we have met also different young women who are experiencing violence, gender-based violence from their families, within their families, because of their status. So they don't know all these challenges that are around HIV, and that is because of lack of information. So it's very, very important that before you say that HIV is like a fever, you should have proper information, the correct information around HIV, and right now and sometimes they say that because it's very easy to access family planning methods compared to the HIV prevention methods, and probably because they don't know where to go and access these services. And that's why today I'm here to encourage them to always seek out, to reach out to different health facilities. We have different community champions. I am one of them, who can easily direct them, who can refer them to where they can access HIV prevention methods like oral PrEP services, condoms, and other services. Yeah.
Now, one of the things you've talked about is it seems easy because they have not lived that life.
Yeah.
Now, you're a member of the National Adolescents and Young People HIV Prevention Committee. What do you specifically do?
So that committee is to advocate for the rights of all the young people, and it's also to bring together young people to be able to make decisions that affect them, and we usually get these voices from them, and then present these voices to the upper hand, like the Uganda AIDS Commission, for them to take action, or we could approach other development partners like UNAIDS, USAID to and seek for support where there is need for young people, and also to solicit funds for some of the interventions that young people have come up with. Young people are always creative and are always very innovative. So they usually come up with different HIV prevention innovations that to help reduce the stigma, to help support adherence among young people. So, and if there is no support, so and most of them, they don't really have support. So we always, seek for support from different donors so that these interventions are being able to be funded.
Very interesting. Also, we see that of late, girls between 15 to 24, I was reading a report from UNAID and said in Uganda approximately a week we get 570 new infections. That sounds a big number, and I know Doctor will comment about that later. But being a young lady, a youth in this, what do you think is the major cause of this?
So the major cause of all these new infection rates among young women, number one is the gender-based violence that we go through. And young women generally have, they have lower negotiation power when it comes to relationship. They're not able to negotiate for safer sex with, for example, if you are a 15-year-old, we have 15-year-olds who are dating older men, like men who are 10 years older than them. So it's very hard for you to tell this person, wear a condom. So or to tell them that, let us, take PrEP. So it's always hard. Like the girl is already vulnerable to contracting HIV. I'll give an example of my friend at campus who one time started dating this old man. The guy was in 40s and she was in her 20s. So and this guy was living with HIV. So, but what really helped her was she had a friend like me who was openly living with HIV, and I would advise her accordingly. So, but there are other young women who don't really have friends like me, who don't know where to seek support, or someone who could guide them on how to protect themselves, or how to negotiate for safer sex. So that puts them at a vulnerable state to getting infected. And also we have, right now, if you look at the available HIV prevention options for young women, they're they're limiting. So if you, for example, a PrEP, the oral PrEP, the current PrEP that we have, it's not a discrete method. So
what do you mean by discrete method?
So like, okay, so something that is discrete, something that I could take without my partner knowing that I'm actually taking. For example, I'll give an example of family planning. There's some family planning tool methods that we use that you wouldn't even know.
Definitely.
That we are using them. So we need those methods, and right now I'm very glad that the National Drug Authority was able to approve the newly approved the new HIV prevention tool, the Deprivine ring, so which is going to be a discrete method for a life-changing tool for very many young women. So with such tools, and there are other more that are in development. So if we have more of them available for young people, and especially young women, so that they can choose, because someone may be comfortable using oral PrEP, others may be comfortable using the PEP, and others want the injectable PrEP, which we are yet we are anticipating results by the National Drug Authority. We are anticipating regulatory approval by the National Drug Authority, and also if we could have and others may be comfortable using the Deprivine ring. So if we have like a basket of options that they could choose from, we'll be able to manage the new HIV infections among the young women.
Well, very interesting revelations there. Now, coming back to you, Dr. Daniel, in the fight against HIV/AIDS, one is ensuring people know their status, and we know that testing, I want to say effectively, that is readily available. Now, the biggest challenge is getting people on treatment. Do we have enough treatment for persons with HIV/AIDS? Second, do we have the right knowledge out there for people to be able to access these various forms of treatment? Are they affordable? Are they accessible? And also, do we have the knowledge? We want to address this because this could be some of the encumbrances to effective or adherence. So a person will take their drugs today, tomorrow they're off. I have a friend, one time I went to visit his sister, and I was like, but you know, brother, let's not beat about the bush. When I look at this person, I'm not 100% sure, neither am I 50% sure. But I advise we do an HIV test. Told me, no, when someone discovers they have HIV/AIDS, they die because they fear. A person can live 20 years without knowing their status and they're healthy. The moment they get to know their status, give them a year, they are gone. So if she has, don't bring that here. Then when I told her, I said, now when you begin treatment, that treatment that they give you, if they look at you and you seem to be a youth and you seem to be lively like me, they will give you treatment that will kill you very fast before you spread to others. So let's look at some of these confusions.
Thank you. I think you bring up a perspective that will be key, if resolved, to meeting our national commitment. Our national commitment of ending AIDS as a public health threat by 2030. We realize at the Uganda AIDS Commission, we shall end up defaulting on our commitment because of simple things, like not giving accurate information to the people. And unfortunately, there are so many people conjuring up false information. And it looks like false information is more easily accepted by people than the truth. But I want to take this opportunity to call upon our leaders, all leaders, religious leaders, political leaders, but also service providers at the health centers. As the Uganda AIDS Commission, we continuously do research across the country to establish the levels of knowledge. Do people have accurate information about how HIV is transmitted? Do people have accurate information about how HIV is not transmitted? Do people have accurate information on the available options, available services for prevention and treatment? We find our people don't have information. So I use this opportunity to call upon the media. The media are a key partner in amplifying these messages. Any message, anything you learn about, take an opportunity to share it with our people. The good thing is that media personalities, people are listening to you. So many people learn from the media. So we're counting on you as key partners in the response to deliver the accurate message to our people, but also to correct the false messages. So the false messages you picked in the community kind of help us correct them. Now, this is how you're going to correct them. I must emphasize that all HIV treatment in the country is free of charge. If you choose to get your treatment from Nakasero Hospital, it is because you have chosen to go platinum, but the treatment they have in the hospital, which has been given to them by the government of Uganda, is actually free of charge. So if you cannot go to Nakasero Hospital, go to Naguru Hospital, go to Kiswa. So all treatment, whether for prevention, whether for treatment, is free of charge. That should be made clear. So the issues of affordability doesn't arise. The second, we have tried as much as a government program to make this treatment accessible. At least all health center force in the country offer HIV treatment. Even where there are no health center force, some health center treats are offering treatment. So we have tried as much as possible, and we're implementing various other innovative models, including outreaches, to get this treatment accessible. We have come up with what we call differentiated service delivery models to make it accessible, to remove all the challenges of having to go board a bus to go to the health center. There's so many models of service deliveries within the community that we have come up to deliver these services to the people. Our key main challenge remains stigma. From the story you tell, people have so much false information. They do not know. That's why these days we have experts who have lived with the HIV for up to 30 years. And they have lived this long because of treatment. And the good thing is, I have one expert who usually is on TV called Dr. Watiti. He's a national expert in HIV treatment. He tells us that when he started HIV treatment, he was taking 17 pills per day. You can imagine the burden of taking 17 pills per day.
Like
the treatment we have now is 1 pill per day.
Sure. 1
pill per day.
One.
So there should be no excuse. I don't know where these people live. There are so many people who are living positively, are having careers. They are important government officials, courtesy of effective treatment. So treatment works. Treatment is so convenient now. Treatment is is accessible to you within your community. Treatment is free. There's no excuse to not go for treatment if you test and find HIV positive.
Now, doctor, what happens when people talk about having run out of refills?
So there are several issues that must arise there. So usually when you go for treatment, they don't give you treatment for a whole year. No, they give you treatment for a certain period of life, a certain period of like 3 months. And the doctor wants you to come back. Number one, they want to see you, because sometimes a person can develop resistance to treatment. Or the person may become lazy and fail to take their treatment. So you need to stay in touch with the doctor for monitoring. So that's why they can't give you for 2 years. They require you to come regularly now. So when you must go back for a reappointment to get a new stock, to give a doctor a chance to monitor you, to do certain tests to monitor, is the treatment treating you so well? Are you taking it so well? Is it giving us expected results? So that is what we call refill. You must come back to the hospital. So sometimes people have challenges. They have other appointments, job appointments. Some are employees. You are a housemaid and your boss has gone on safari. You cannot come. But we have come up with innovative ways, things of young people. You don't have money at the time to go for your refill. But we have come up with various innovative ways, including innovations led by young people themselves, like my colleague has talked about, to make sure we overcome the anticipated challenges of all our people on treatment, to make treatment as convenient for them as possible. So, back to your question, the government has enough treatment for all our people living with HIV. But I must also emphasize, the government cannot afford treatment for every Ugandan. If every Ugandan was to be HIV positive, then we shall be scrambling for these drugs like we scramble for amoxicillin in the hospital. I hope you have been to hospital with cough, and they ask you now, there is no dagara, you must go and buy from the pharmacy. Because ARVs are expensive, so the people who are busy celebrating that because they are ARVs, they will abandon the prevention Because once you contract HIV, you can take medication. I wanted to emphasize the fact that as much as there is medication, the government cannot afford medication for everybody. So if we keep on increasing the numbers of people who have HIV, we shall be scrambling for ARVs, like we scramble for Panadol in the hospitals, which is not a good situation. Because ARVs must be taken religiously. You don't miss a dose. So we cannot afford that. So make sure you do whatever you can to prevent really acquiring HIV. We have so many tools for you, and I hope as we go along the conversation, I will be presenting these tools to the people.
Well, you're still watching UBC TV on this day when we are commemorating World AIDS Day. And we are looking at fighting stigma and, of course, various forms of inequality or discrimination amongst people living with HIV/AIDS. Now, coming back to you, Ruth, there's one thing I've experienced with people that are living positive lives. They find it hard to get their drugs, not because they are not there. I have a friend, he's in Mbarara, but he has to come to Kampala to get his drugs. I asked him, why don't you get these drugs in Mbarara? He said, what if by any chance a person who knows me finds me lining up for my drugs? Have a young friend of mine, she's an ambassador, and for her she's comfortable saying this and that. But she always tells me that every time I never get, even when I find another person who has come to take the same drugs I've come to pick, you know, they greet me with a shock. But we've come to get the same drugs. But the other person creates a way of stigmatizing. Told me, and said sometimes even medics also may look and wonder, in case you're maybe still young, or when even you're very old and they wonder, hey, Muzei, what happened? There are places I've ever gone to that I felt they're so professional, like Baila, Uganda, Mildmay, and really I appreciate such institutions that are doing a very tremendous job in the fight against HIV. Baila, Uganda, I think they work more with infants. Mildmay still, they do the same. But how can we address this issue of stigma? That much as government provides the drugs, still someone may simply fail. I know VIPs in this country. Doctor, when you talked about that they want to review you and see you, I know VIPs who never collect these drugs. He'll tell you, my refills are down, but my driver went to the village. Have to wait for my driver. Someone, you see, they befriend the askar, and you're like, what is the connection? This guy has to go and pick them on their behalf. How do you overcome this?
Okay, first of all, the issue with stigma and discrimination, it's still a very, very big challenge in addressing, in addressing the HIV itself. So I would say one of the driving factors for stigma and discrimination is the laws and the policies that we have in Uganda. When you look at the HIV HIV and AIDS Prevention Control Act, so there is where they state that, so that there is where they always have, there is that statement that says that if anyone intends to transmit the virus, there is that, I have to...
Close.
Yes. So there is that clause that says that the intentional transmission of HIV leads to... it's a crime, yeah? And that calls for fine or 5 years in jail. So which is I find it very stigmatizing, because it was not defined what unintended mean, like so intention, because sometimes people, like especially among young people, where you have a partner, you love this person, and you're scared of rejection. So in that moment, you want to save your relationship, and You're going to keep quiet, but your intention is not to transmit this virus. But if someone else who will come across that clause, and maybe accidentally you infect this person, so definitely that is a crime in Uganda, and that person will be punished. So that alone stigmatizes people living with HIV, and we have, especially men. Men are people who the way they are brought up is to, you know, be a man, don't open up about your issues, about your mental health. So they always close out, and this is one of the reasons why we have also very many HIV infections among young women, because men don't speak up, they keep quiet, and even though it's not their intention to spread the virus. So opening up, so opening up among people living with HIV about their status, it's always just the debate you have. I'll use my live example. So you have this person, and just the debate you have with yourself on whether should I disclose or not. It's very detrimental, and it heavily impacts on your mental health. Just alone that conversation you have yourself.
Because you believe opening up may mean the end to the relationship.
Yes, opening up, and you don't even know how this person is going to react, because even the person that you trust is going to you definitely, that person, if they're not informed, if they're not well informed, they are going to reject you, or they're going to spread rumors with you. I have a friend recently who reached out to me and was like, Ruth, I'm so depressed. She had just given birth, and she had a friend who was helping her throughout the whole birth process. And the moment she found out that she's HIV positive, that was the end of their friendship. So, and on top of ending the friendship, she had to go around and tell people about this person. So now, like, it's scary just to open up, and the environment that we have, the environment itself that we have for people living with HIV is not favorable for us to live a vibrant life, to live a free life. So if we could also have, if people are sensitized about HIV, because in most cases people who do that, who stigmatize people living with HIV, lack information, especially on how to protect themselves. That's for the case of the partners, and they don't even know that right now we have the U is equal to U, whereby if you're undetectable, you are not able to transmit the virus. So people don't have this information. People don't have this information. So we want to work with the media and different influencers and to educate the public about HIV, in general, and also we want the government to repeal these laws that stigmatizes people living with HIV, and also even we have some categories of people living with HIV, the key populations. So just alone, if you look at people who are doing sex work, so just that alone is also what? It's a crime in Uganda. And if a health worker finds out that this person is a sex worker, or this person is a gay person, so they would even refrain from providing the services that these people need, instead of looking at this person as a human who needs these services. So like, there's a lot of work that we need to do, and it's not a one-day job. But if we could collectively be responsible to fight against stigma, we'll be able to end the stigma that we are currently experiencing.
Well, Doctor, I wanted to supplement something.
Yeah, thank you. I wanted to highlight that we have made progress in fighting stigma. Stigma has significantly reduced, especially what we call stigma. Stigma from the outside, from your peers, from your family, from your workmates. It has significantly reduced, but it is still there. The main form of stigma that we still have to challenge is what we call internal stigma. Yes. When you describe of an experience of a boss who sends his driver or his security guard to pick for him refills, I don't think most of the trouble is outside there. Most of the trouble is that he imagines there is trouble there. There are hateful people there. So, but also what gave birth to this internal stigma is what we did in the past. In the past, we treated people with HIV badly. And you saw it when the COVID pandemic had started. The people who were being discharged from hospital with COVID, after recovering from COVID, the communities were ganging up against them. They were stigmatizing them, discriminating them. Only that we had learned a terrible lesson from the HIV response, that stigma is disastrous. So as a government, as a national HIV response, we have come up with the National Anti-Stigma Policy, signed by His Excellency. We don't want stigma. If you come to the Presidential Fast Track Initiative on Ending AIDS by 2030, which was launched by the President, developed by the President himself, just interviewed a few technical people and gave guidance on what needs to be done. His commitment was, we don't want to see any stigma in Uganda by 2030. But there is still stigma. We have launched the anti-stigma policy guidelines, and as my sister says here, the policy guidelines aim to show people. Many people who are stigmatizing are not even aware that what they are doing is causing pain to their colleagues and fellow men and women. So the policy aims to show certain leaders how to communicate about stigma. How does it present, and how to condemn it. So we have gone around the country disseminating these policy guidelines. It's a government position that there is no need to stigmatize a person living with HIV. For us in the national HIV response, if we do not end HIV-related stigma, the probability that we shall attain our goal of 2030 reduces. So attaining our goal of 2030 means that all our brothers and sisters who are living with HIV feel they are free. People who have diabetes in this building, when it is time to take their medication, they pick their tin, and they take. But people with HIV, they need to hide first. So we would want to remove that, because I don't think a person with diabetes feels they are worse off or they are better off than somebody who has HIV. So why should one feel ashamed and the other? It's us who created it. Provided our people living with HIV are not taking their medication freely and without shame, then our chance of ending further HIV spread gets reduced, because the people are not going to attain virus suppression. And that problem is most especially among young people.
Now, Doctor, let's look at the role of various stakeholders in the fight against stigma. Away from saying we just have a policy, what should they be doing?
Thank you. I think the first thing they should be doing is to spread information. Like Ruth said, stigma feeds on lack of information. So the stigma we are suffering from right now, the HIV-related stigma, was birthed at the time when we had little information about HIV. We have so many young people who were born with HIV. So where do you get the moral authority to say HIV is a disease of moral authority, of morality now? We have so many men or even women who got married, who were faithful.
Yes.
But you get married to a person who had moved around. Where do you get an authority to call that person of a lesser moral quality? So we have demystified the idea that AIDS is a moral issue, because so many people, including children, who had nothing to do. So what gave rise to the stigma we're suffering from is because we had no information. So we call upon all leaders, wherever they are, to correct the error. It was an error that must be corrected, and it will be corrected by passing on the accurate information. People need to be informed. If people have accurate information, they will not. If people knew that actually treatment does not kill, if somebody informed all our people and convinced them, and there are various platforms, It's a multi-sectoral HIV response. Now, in the multi-sectoral HIV response, we find that there are key stakeholders who are strategically positioned to have the audience of every Ugandan. One of them is the religious leader. We are calling on the religious leader, and some of this stigma was created by the religious leader. The religious leader is the one who moralized HIV. So they must correct that error that was made. HIV is not a moral disease. That's one. But they must also help us. They have the greatest platform. Every week, and we listen to them religiously, pass on accurate information about HIV. Tell people that HIV treatment does not kill. It helps people to live long. They are national examples, people who have stood tall and they are available for their names to be used as reference. I've just talked about a person like Dr. Watiti, another person like Major Baramera Ram. They are our national heroes. They're standing tall, saying, I am here, living a healthy, vibrant life. Use my story as an example. Let the religious leader use those stories to empower people, not to spread stigma.
Very interesting, my
So
fellow.
the other people who have the platform are the media. The media, you are a key partner in the national HIV response. I think perhaps we need a meeting with all the media houses in this country to tell you how much we're counting on you. Because the Uganda AIDS Commission has like 50 staff. We cannot be all over the country. If we are saying we have to move across the whole country, I think it will take us like 100 years to reach everybody. So we are counting on the media stakeholder, the media fraternity to amplify the message, the accurate message that kills stigma, that empowers people with information to take care of their lives, to avoid acquisition or transmission of HIV. So we are counting on you. If we fail to attain our commitment of ending AIDS as a public health threat by 2030, it's not because that we don't have the tools. We have enough drugs and all the tools. It is because our people didn't know that these tools were there. It is because people were not empowered to use these tools because there was stigma surrounding them. And it may be because the media did not play the right role. They did not play their part exhaustively. We're counting on you as media. It is a countdown to 2030. We need to accelerate. We need to get in a really super turbo gear. Turbo. We need to get into turbo mode because 2030 is close and we must defeat this pandemic.
Well, time is not so much on my side, but as I wind up, let me have your final remarks, Ruth, regarding fighting stigma and discrimination amongst people living with HIV/AIDS.
I just feel that we have really exhausted a lot on stigma and discrimination today. And one, just to re-emphasize and re-echo what Dr. Dan has said, that people to be informed. Yes. And
Any? You have the opportunity.
and also, then secondly is for people to be able to know their status. And right now we have the HIV self-testing kits. So that was brought in place to also address the issue of stigma and discrimination. So we have the HIV self-testing kits called the Aura Quicks. You can go and access them in different health centers at Mulago, Beira, Uganda, Maudme. So you can go and access these self-testing kits and so that you're able to know your status firsthand without a health worker without a health worker telling you. Because some people, they want to know and, maybe first process the whole thing and then get to access the services.
Well, Doctor, as we come to the end of this show, what is your final remark?
Thank you. Rated stigma. Of course, when I look at the country, I want to share like statistics. When you come to the southwestern region, the viral load suppression is at 83%. When you go to the eastern region, the Busoga-Bukedi region, the viral load suppression is at 60. It sounds like there is greater stigma in certain regions of the country. So at this moment in time, I want to call upon the people in the eastern region, in the Busoga-Bukedi area and the surrounding areas. You are being left behind. The leaders from that region, we are calling upon you. We are fighting inequality. The people in eastern Uganda are being left behind, and we are seeing so much HIV transmission in that area because most of the people on treatment are not attaining virus suppression, and we know it's related to stigma. Let the focus be there. Let the leader do some work. We're also seeing a challenge with men. I am calling upon men. We are being left behind. The women are taking treatment in spite of the number of people living with HIV, the greatest number being women. When it comes to dying, it is mainly men and young people. So I'm calling upon men and young people, especially young men, don't be left behind. There is HIV treatment. It is free. It is very effective. Major Baramera Ranga has taken it for close to 40 years and is still a vibrant, healthy man delivering for the country. I think he's in charge of Operation Wealth Creation now. He's vibrant all over the country. Be part of this. Don't be left behind. But most important, let's avoid contracting HIV, those who have not yet contracted, because the government does not have money to put every Ugandan on treatment.
Well, I want to thank you so much, Dr. Daniel Byamukama, who happens to be the head HIV Prevention Uganda AIDS Commission. Thank you so much for your time, and of course those words of wisdom and knowledge, and also facts at table that, well, not government will not be able. So let's ensure we don't have more people joining, taking treatment, but avoid that. And of course, it was also a pleasure having you, Ruth, who is a member of the National Adolescents and Young People that aim at pushing for prevention against HIV. She's a committee member. Thank you so much for your time. And of course, she talks so much about let's fight ignorance. Some people are stigmatized because of ignorance. They're telling you things you don't click, but you're becoming more wiser. So let's first seek for information. One great man said, he who hasn't researched has no right to speak. So let's all interest ourselves in knowing about this disease. And lastly from me, please get to know your status. Give yourself on this day by knowing your status. If you're positive, begin treatment. If you're negative, stay negative. And together we shall fight HIV/AIDS. Come 2030, we will have achieved that global target. God bless you. Have a lovely day. Welcome back.
Live from UBC Studios in Kampala. This is Good Morning Uganda Extra.
UBC, inspiring Uganda.